Today we're talking about pain management when it comes to bone metastases. I think a lot of times prostate cancer patients can have cancer and then they're very aware of what's going on in their body, and maybe they're wondering, is this ache or pain prostate cancer or is it something else? So today we're going to talk to Dr. Mark Scholes, who's a 30-year medical oncologist who's focused solely on prostate cancer. We're going to talk about different types of bone metastases and when you would see them on a scan. Really, if the pain you are feeling is prostate cancer or if it's something else, and what to do if you are experiencing that pain. I hope you find this helpful. So today we're talking about pain management. When it comes to metastatic prostate cancer, the prostate cancer has left the prostate itself and now it has gone past the lymph nodes and into the bones. And a lot of times we see, these ads that come in that say, oh, this pain is a symptom of prostate cancer. So maybe we can address just pain being a symptom first and then talk about any pain that is caused from metastatic lesions on the bones.
Well, in the early years of my career, the management of bone pain, people would, before we had PSA testing even, people would come in, something was hurting, and that was a sign they had metastatic prostate cancer. These days, with PSA testing, occurrence of bone pain is actually very rare in my day-to-day practice. So two causes for bone pain are the misdiagnosis, where someone is not screening and detecting the condition before that problem occurs, or in a situation where someone has been through many layers of treatment and the particular genre of prostate cancer that they have is resistant to these different treatments, and therefore the disease is uncontrolled and spreading and causing pain.
What exactly causes the pain on the bones? Do we have nerves on our bones that are causing that, the cancer's there, and is it eating away at something? What is the pain caused by?
Typically the bone marrow is where our blood is made. That's where the cancer shows up, and then as the tumors enlarge, they start pushing against the bone itself, and yes, there are nerves that are uncomfortable. Interesting thing about this phenomena is that the pressure from the growing tumors, if it's even slightly reversed with effective treatment, the bone pain will rapidly improve. Whenever we initiate new treatments, we're always waiting to see if they're going to work or not. And one of the earliest signs of effectiveness is the rapid resolution of pain.
So when you say the rapid resolution of pain, is that within a couple weeks, a couple days?
Sometimes a couple days, sometimes a couple weeks. Usual markers that we use, PSA testing, repeat scans to see if spots are getting smaller or disappearing. Those take a longer interval before you're going to start to see a reversal and prove that you're on the right track with the treatment that you've selected. Idea of being vigilant for the reversal of bone pain that, of course, has been previously confirmed to be from prostate cancer. As people get older, they have pains and aches and all kinds of things, but cancer pain is distinctive in that it's usually persistent. It doesn't wax and wane. And progressive. Areas of soreness have usually been confirmed by a scan that matches to that area. So if someone says, I have a pain in my hip, doctor, and it's persistent and progressive, characteristic of cancer, then that should be matched by a scan, a bone scan, a CAT scan, a PSMA PET scan that shows uptake of cancer in that area. If something isn't visible on a scan, it is almost impossible that it would be prostate cancer. Painful prostate cancer is always visible on scans.
Before I get to my next question, I just wanted to remind you that this September we're having an in-person prostate cancer patients and caregivers conference. It's a great way to get your questions answered, and you can learn more at pcri.org. Also, don't forget to click that subscribe button because it's a great way to support our channel, and if you would like to support us financially, you can do so at pcri.org/donate. Now back to my conversation with Dr. Scholes. So what are the most common locations that somebody would experience pain from a bone metastasis?
It's probably easier to talk about the places where it doesn't occur, which it would be, say, below the knees and past the elbows out into the wrists and hands. There have been very rare exceptions to that rule of thumb. Apart from that, prostate cancer can show up pretty much in any bone, and it doesn't necessarily have to be close to where the prostate was, because the cancer that spreads to the bones is circulating through the bloodstream and landing in these distant locations. So pretty much any bones in the body except for below the knees and below the elbows. I've seen a couple exceptions to that in my very long career. Extremely rare to see cancer outside of those areas.
So with patients who have not yet embarked upon treatment, maybe they haven't done hormone therapy, is hormone therapy the first line of defense against bone pain when it comes to metastatic lesions?
Bone pain, rather than being managed necessarily with pain medicines, you can use them as a bridge until your treatment starts to become effective. But the main management is to initiate effective therapy to control the cancer. And if that treatment is effective, it will reverse the pain very quickly and it will keep the pain away. You mentioned hormone therapy, which is one of the most effective anti-cancer treatments for any type of cancer in the world. Unfortunately, only works for prostate cancer. Is certainly a very logical first choice. There are some medicines, however, that you have to be a little careful with. Lupron and other LHRH agonists, which cause a temporary rise in testosterone after injection. So medicines that cause the testosterone to drop directly rather than rise and then drop, the ones that drop directly are the ones that need to be selected in people that are having pain, as the pain could get worse if there was a brief flare of testosterone with the initiation of treatment.
How long does that lupron flare last?
Say a week or two. One policy historically, when we had fewer tools, was to give some Casodex leading into the shot and for a couple weeks after. It's reasonably effective, but with medicines like Firmagon and Orgovyx now, which or Zytiga or Xtandi, Nubeqa or Erleada, these medicines just completely shut off testosterone immediately. Those are the medicines that should be initiated if someone is having bone pain.
What is Casodex and what did it do in that situation?
So Casodex blocks the androgen receptor, very similar to the way Erleada, Nubeqa, and Xtandi do, but Casodex is nowhere near as potent as Erleada, Nubeqa, and Xtandi. So we're not using much Casodex anymore, except maybe in elderly men with mild cancers that we're trying to control with and minimize side effects.
We talked about it in the situation where somebody is still sensitive to hormone therapy. What about people who are no longer sensitive to hormone therapy and it's not working? They have metastatic lesions and now they feel that pain. What are their options?
So you always want to control the cancer if possible because people live longer. If the cancer is controlled, you'll control the pain in the same vein. The backup treatments for people that have become, say, resistant to typical lupron medicines or second-generation hormones, chemotherapy, immune treatments, spot radiation, systemic radiation, lutetium, Xofigo, and the like. Oncology oversight will usually be looking at all these different treatment options and selecting the one that is most likely to be effective and have the best quality of life or the lowest number of side effects.
What about in situations when, we mentioned spot radiation? How does that process go? Is there a point where there's too many lesions to spot radiate? Do they need to be under 5? I know we talk about oligometastatic, disease under 5, but there's two different situations there. So is spot radiation applicable to both?
This is an evolving area with the advent of better scans and also a better understanding of oligometastatic disease. The historical methodology for giving radiation to people with bone metastasis was to give a modest to above average dose of radiation to get rid of the pain. There was no real thought that maybe curing the lesion would be advantageous because there inevitably would be more lesions, and the whack-a-mole rearguard action to fight cancer really was not in the mentality of people who were treating prostate cancer. That certainly has changed due partly to research showing that if there are a limited number of spots, that sterilizing those spots with higher doses of radiation is advantageous. And now with PSMA PET scans, where we're finding the spots much earlier, that doubles down on that same philosophy. So people that are having pain but maybe have a limited number of sites do have to have a conversation with their radiation therapist about what the goal is for the radiation. Is it merely for pain control, which might be a lower dose in someone who's in a palliative situation going on hospice and not anticipated to live very long, versus someone that's perhaps presented with metastatic disease and has a painful spot. And the radiation therapist has got the old-fashioned thinking of, I'm just going to give a mild dose to control his pain, not realizing that a more modern viewpoint is to try and cure that spot with higher dose radiation. Both will cure the pain, but by giving partial radiation to a lesion that may actually muddy the waters and make it more difficult to give full dose radiation to that same spot in the future.
What about in situations where maybe spot radiation isn't an option? Do we see things like Xofigo or Pluvicto taking away metastatic lesions and alleviating pain as well?
Yes, definitely. And we don't hear so much about Xofigo anymore, which is injectable radiation that goes to the irritated areas of the bones. It doesn't go for the cancer itself, but the areas where the bones are irritated is usually where the cancer is, and it certainly can relieve pain. It's been associated with pain control, and it's a well-tolerated medicine. Pluvicto, being an effective medication for prostate cancer, just as any effective medicine, is able to reduce pain by shrinking the tumor size. If we remember that the tumor is hurting because it's grown to a place where it's pushing and pinching a nerve, and even a small amount of tumor shrinkage will relieve that pain. Pluvicto or any other effective treatment is certainly a plausible way to control pain.
In situations where you have patients who are either trying to, in the meantime, figure out what treatment they're going to get to handle the bone pain, maybe they just need something to take in the meantime, we have these analgesics like Advil and, Tylenol, acetaminophen. Are these things that you're telling patients to take? Are there stronger medicines that they need to look into and talk to their doctor about?
Prostate cancer spreads typically to bone and to lymph nodes. Usually lymph nodes don't hurt, you don't feel them. And so with bone pain, the interesting thing about it is that the common over-the-counter medicines like Advil, Aleve, ibuprofen tend to have as impact, and sometimes even more impact than narcotic medicines do. Everyone's different, and there's a bit of a trial and error process. These medicines can be used in combination, narcotic medications plus Advil or Aleve, or Tylenol, which you mentioned. While waiting to, get the doctor's appointment, spot radiation to a painful area will relieve pain very quickly, but it take a few days to get an appointment, a few more days for the radiation to kick in. As a bridge, these pain medicines are usually quite effective. Narcotics work by an interesting mechanism. It's not so much the direct relief of pain, but how we perceive pain is also painful. Our own fear of pain is painful. So narcotics seem to take away that awareness of pain. The pain is still there, and when you ask someone taking a narcotic pain medication, do you still feel the pain? If they think about it, they can say, yeah, I can feel it. But it isn't troubling them as much for some reason. The ibuprofens and the Aleves, they have more of a direct effect on the lesion itself and reduce the pain threshold. And so even a combination of these two things can be more effective, Aleve or Advil or ibuprofen plus a narcotic medication.
Is there a minimum dose that you start patients at and then gradually escalate it if the pain continues?
The whole world of pain management it's a specialty. There are doctors that literally are devoted exclusively to pain management, and they become very skillful at this sort of thing. And it's a trial and error process, and there are side effects from these medicines that, excess somnolence, constipation, irritation of the stomach wall with ibuprofen, Aleve medicines. There is an art to it, and each patient reacts differently to these medicines. Sometimes there's interactions with other medicines. You don't want to be taking sleeping medicines plus narcotics. A refined and expert approach is necessary, and usually, yes, you would start with smaller doses to see how each individual reacts.
One of the things that I think it's important to mention is that if a patient feels bone pain in their spinal cord, there's spinal cord compression, and that does need to be taken care of quite quickly. Can you explain what that is and the urgency behind needing to take care of it?
Yeah, there are very few emergencies in the prostate cancer world except for this phenomenon called spinal cord compression. So we talk about the tumor expanding and pushing on a nerve, but what about the situation where the tumor is expanding and pushing on the spinal cord? This is the main nerve that runs from the base of the brain down to your tailbone, and a bunch of nerves come off the side. Basically, it controls your whole body. So if the tumor pushes against the spinal cord, starting in the bone, growing outside the bone, pushing against the spinal cord and forcing it against the other side of the bony canal, cutting off the blood supply to the spinal cord, it can cause irreversible destruction of the spinal cord below that level and lead to paralysis, paraplegia or quadriplegia if the lesion is very high in the neck. So it's an emergency because this can be silently progressing along until the time when all of a sudden because it's pushing against the cord so much that it's cutting off the blood supply, there's usually a sudden upgrade in intensity of pain, very noticeable. It may be accompanied by some loss of function, weakness, or loss of bowel or bladder control, or loss of sensation, below that level in your body, but that doesn't necessarily have to be the case in the early stages. Usually the first thing is someone may have had some soreness in their back, but all of a sudden, overnight or in an instant, it's serious and severe. That's an emergency that requires hopping in the car or calling 911, going down to the emergency room and getting an MRI of the spine to see if the diagnosis is correct, that spinal cord compression is actually occurring. And those patients need to be put on high doses of steroids, usually Decadron, and rushed in to get radiation, sometimes even surgery to release the pressure on that area of the spinal cord.
Being diagnosed with cancer is obviously a very intense situation. I think it gives a lot of people an awareness of what's going on in their body, what they're feeling, and they're more aware of what their numbers are, the situations that they're encountering. And I think that sometimes people can feel pain when they're in a cancer diagnosis and they're wondering, is this really something more serious? Is this a cancer spot that I don't know of? And that can happen, throughout time, because we have all these aches and pains. You can, pick up something the wrong way and all of a sudden it hurts. So how can a patient really be sure that the pain is not from the cancer, but it is just from maybe daily activity or some other injury?
Right. I get questions like this all the time. And the first thing I do is I ask about the character and the timing of the pain. Prostate cancer pain is going to be unremitting and often progressive. So a lot of the pains that we have are shooting pains, and it hurts for a little while, it gets better. Pains that are in our joints, as men in my age, we get sore joints. Prostate cancer doesn't spread to joints. It can spread to bone, but not to the joints. Talking to someone who knows their way around this world a little bit can alleviate a lot of these concerns about the many pains that we all experience every day. Bottom line, of course, if there is a suspicion of pain from prostate cancer, the doctors are going to look at, well, what's the PSA doing? If the PSA is continually rising, then that raises a question of progressive cancer. And then the other big question would be, what do the most recent scans show? As I said earlier in this video, that a spot of prostate cancer that is hurting will always show up on scans. We do know that micrometastatic prostate cancer can exist around the body that is not detectable on scans, but I can guarantee you those never hurt. They're too small, they don't cause pain. Painful metastatic lesions need to match where the pain, if someone says, my leg is hurting right here, Dr. Scholes, and you get a bone scan or an MRI or just a regular old x-ray, and there's nothing there, there's nothing visible, then we have to look for another reason besides prostate cancer.
So there are a couple of things that I want prostate cancer patients to talk about with their oncologist. If you are in pain, don't just tell your caregiver, don't just say, hey, I'm feeling this. Bring it up to your doctor. Talk to your medical oncologist or your primary care physician. Typically, it is the oncologist that you talk about, but they can refer you to a pain management doctor as well. And what I would do is keep a pain management diary. I would look at it and say, okay, here's where I feel pain, and I feel it from a 1 to 5 range, maybe it's a 4. And then when you talk to your doctor, you can say, here's where I feel it, it's a 4, what can be done? If he either is giving you an analgesic, you can find out, okay, well, this is how effective it's being, and after maybe a day or two, just write down, on this date, this is level 4 pain went down to a 2 or a 3. Maybe he's, giving you a treatment. Maybe you're going to go on hormone therapy, or you're going to get spot radiation or something like that. Then you can write down the time of the treatment, what the pain level is at that moment, and then maybe in a day or two, in a couple weeks, you can continue to write down where your pain is at. And if there's still residual pain and you're concerned about it, again, you can talk to your doctor and call him back and said, hey, I have the treatment, this is still bothering me. And especially in situations if it's near the spinal cord, I would definitely talk to your doctor and get that checked out. You want to make sure that you're not in a situation where you have a spinal cord compression, because it can be very serious, as Dr. Scholes mentioned, and it is an emergency situation. So it's an important thing to look ahead of time if you are feeling pain in your spinal cord and maybe you don't feel that loss of sensation, but you do feel something there. Bring it up to your physician. You just want to make sure that we're getting things checked ahead of time. And a lot of times I just see men kind of bearing through it. They think this is part of the cancer diagnosis, that they have to take the pain, and that this is part of the process. But in reality, if your doctor can give you something that helps your quality of life, that makes it so you don't have to be in so much pain, and you can go through the prostate cancer, treatments or any situation just a little better, please do it. Watch out for yourself. Speak up. tell your caregivers, and just get the help that you need. If you have questions, you can go ahead and contact our helpline at pcri.org/helpline. There are prostate cancer patients who have been through these situations, and they can give you a lot of help. They can get you ready for your medical appointments and even help you write down your questions for your doctor. But it's a great way to get the help that you need and to get you ready for your medical appointments, and even bring your caregivers along. It's a really great way to get support. Please remember, you're not alone, and I hope you have a great week.